So, hey, Jordan, I am so glad to get to talk to you again today. We talk a lot, but this is kind of an important topic that you and I discuss, on a professional level. We discuss sometimes personally just because we want to talk about how things are going. First, how about you tell everybody who you are and what you're doing right now?
Hey, absolutely. Pleasure to talk to you. Also, my name is Jordan Johnson. I'm the Director of Data and Analytics at Legion Healthcare Partners, also the Director of Compliance. So I look at the billing, the coding, the compliance aspects, and then also how are we using data in the medical imaging and radiation oncology professions. So that's what I do. We look at efficiencies, look at ways that we can dial in what our payers, what our doctors, what our um, management, supervisors, what they're looking for in us as technologists.
So, Jordan, how about let's just start with the basics because I know so many people, imaging professionals, radiation therapists, other medical professionals, nurses, they're so overwhelmed and so busy doing their jobs, whether that's I'm a CT tech or I'm a radiation therapist or I'm a nurse practitioner. They're so busy doing their jobs that they don't think, maybe they don't understand that billing is part of that job. And I've heard you say before, if you get a paycheck, billing's part of your responsibility. So let's just start at the beginning. And how is billing everyone's responsibility?
Oh, absolutely, absolutely. And I think it's sometimes a misconception that we can trace all the way back to the educational programs. So whether it was medical imaging, radiation therapy, nursing, obviously the majority of the focus was on the clinical component, taking care of the patient. And taking care of the patient is always the utmost and should be the foremost priority of what we're doing. But there's also what I call the support mechanism, and that is revenue. Is those that are on the front lines are ultimately responsible for capturing the work that they're doing. So we know if it's an X-ray tech and we did a two-view chest, or in radiation oncology if we did a prostate treatment, we capture what we did, the work we did, and then that numerical value flows over to the billing system, gets billed out to the insurance company or the patient, and that's how revenue comes in. So you'll hear there's some old terminology in finance and healthcare called no margin, no mission. And really what that is our primary focus is the patient, but to keep the doors open and keep access for the patients to provide services, we're a business. We have to make money. The equipment we use costs money. And so that being said, I think, tracing that back to the educational programs, we're starting to see more of an emphasis and focus on those aspects now in curriculum. It's something that hasn't been tested on as much on the standardized test for your licensure, but we're starting to see that integrated. And really the push on that is the expectation from upper administration, knowing that catching something on the backside is not near as efficient or accurate as capturing what you're doing on the front end. And the people that are going to be doing that, again, are the technologists, the therapists, the nurses, the people actually doing the work.
So it's interesting you said that about the educational programs because actually billing and coding are part of the registry specs for radiography, for radiation therapy, for the other radiation sciences. But I agree with you in that it's not very much of a focus sometimes in those programs because they do focus on the, clinical aspects, the didactic, anatomy, physiology, radiation physics, of course. But the billing and coding and CPT codes are actually part of the registry exam specs there. So that is something that all students should at least be aware of, enough that they can grow and learn more once they get, in their jobs. And then as working technologists or therapists or other medical professionals, it's something that you have to continue to learn. And we'll talk about that here in a little bit, how fast things change and how it is your responsibility to keep up with those changes. But kind of keeping it basic here for a minute, billing and coding are often said in the same breath, billing and coding, but there's a distinct difference between billing and coding. So how about you explain that to us?
Oh, absolutely, absolutely. Yeah, we often hear, the billing and coding department, or like you said, billing and coding is often used interchangeably, but they're very, very different. And we'll split it up in order of kind of the hierarchy that they're done or the chronological order that they're done in. And so coding occurs first. So anytime that a medical procedure is performed, obviously there's going to be an order for it. And then once that procedure is performed, what we call the coding aspect is what occurs. So we pick the corresponding CPT code, the numerical code that matches that procedure. So, and every procedure has one. So again, if you're an X-ray, you know, an L-spine, a T-spine, you know, all the way back to zygomatic arches, all those exams have a specific CPT code. And when you capture that code, when the technologist, when the nurse, when the therapist captures that code, that's actual coding. That's when the coding occurs. Now, again, you're going to go through your day, you're going to perform lots of procedures, you're going to capture those codes. Generally, at the end of the day, the system that you capture those codes in, it could be, you know, ARRT, it could be Mosaic, it could be Cerner, it could be Meditech. You know, those codes are going to move into what we call the billing phase, and that's when it's going to run through a bunch of edits. So the government sets forth a lot of edits, when codes can be billed, what codes they can be billed with. And that's really, when we get into the billing phase, that's what that is, you know, it's checking, was the coding that was done on the front end, was it accurate? And if it was accurate and everything lines up the way it's supposed to, there's no conflicts, then the billing occurs. And billing, again, may be billing to the insurance company, it may be billing to the patient. So that's when the actual billing occurs. So there are two very distinct, different timelines. You know, one occurs on the front end, one occurs on the back end. But they're definitely, they get used interchangeably, and probably by definition should not be used interchangeably, because they are very, very different, and there's different staff involved. Again, you know, your frontline staff is not going to be the ones, they're going to be the ones doing the coding, but they're not going to be the ones doing the billing. There's an entire department for that. Okay. So that, hopefully that clarifies that a little bit.
Speaking of clarification, I know as we go on, there are a lot of acronyms that are used in billing and coding. So let's review a couple of those. So there's CMS, CPT, the OIG. How about you define those for us? And then if there are any others that you can think of that we may need to know as we go forward, add those in there as well.
Yeah, absolutely. So, I mean, that's kind of like, I mean, it's kind of like alphabet soup when you start talking about all the letters that get used just in this aspect of the business. And so first I'd start with the AMA. You'll hear that. The AMA is the American Medical Association. They own the rights to the CPT codes. Those CPT codes, and that's just the procedural terminology codes, and those end up being numerical codes. So, but the AMA sets those definitions, and they come out with new codes, revised codes, deleted codes once a year. Generally, it's once a year. And then those codes, CMS, so we call that, that's the Center for Medicare and Medicaid Services. That's the government. That's who sets the fee schedule. So when you figure out, you know, how much am I going to get paid for these codes, and that's what the hospital is looking at, or how much does my procedure cost, CMS sets those rates for Medicare and Medicaid. So you can see that there is some collaboration between the AMA, the American Medical Association, who owns the CPT codes, and then obviously CMS, who sets the rates for those codes. Other organizations that are kind of involved that you'll hear about for the for the revenue integrity end, obviously everybody knows what HIPAA is. There's other organizations that we call the DOJ, that's the Department of Justice, or the OIG, the Office of the Inspector General. And so when there's the possibility that there may be fraud, or there may be abuse of the billing and coding practices, those are two of the organizations, the OIG, the Department of Justice, that are going to look at and do research into the data to maybe discover that there's been some abuse or fraud. And at that point, they would issue that whatever the facility is that may have either knowingly or unknowingly committed that fraud or abuse needs to pay money back. There's also another acronym called a MAC, MAC, and that's your Medicare contractors, and they're located geographically, they're split up. So we have one called Noridian in the Northwest. We have Novitas in the South that covers Texas, Louisiana, Oklahoma, and Mississippi. And we have CGS, NGS, First Coast covers Florida, And then we also have Palmetto that covers North and South Carolina and Georgia. So those are a step below CMS. So the rules and the guidelines that the Centers for Medicare Services put forth are kind of the highest level, the highest tier. And then the next level down would be your max and those jurisdictions. And they're generally in line with CMS. They may have some additional constraints in the rules and regulations of how procedures can be done, what's the level of supervision, what documentation is required. They may spell things out a little more specific. So those are probably the biggest acronym organizations that kind of govern what we do.
So you said that the AMA owns the codes, and then the CMS kind of governs the codes, and then those different geographical regions have their own responsibilities or governance or organization with the codes. But what is a code? How is a code? I do a chest X-ray. Who determines what is involved in that? How you're going to be reimbursed for that? So what is a code? Where does it come from? And then how does it get accepted or become the standard of care, I guess, for that exam?
Absolutely, absolutely. So every procedure that we do has a code. Now the codes are split up. We talk about radiology, so we'll talk about radiology procedures. The code sets start at 0 and go up. So up, we call the 77,000 codes. Your 77,000 codes are what we call the radiology codes. Those include radiation therapy. They include MRI, CT, PET CT, your ultrasound, angio studies, all that stuff has a code. And then pulmonology, cardiology, GI, all those different service lines that we would say for services provided in the hospital have their levels of code. So they may be in the 55,000 code set, the 44,000 code set. So how a code really comes about is through research. So if a company has a procedure and they want to get a new code for it, so a new piece of equipment comes out, you have to apply for that code. And what happens is it's assigned a T-class code first. And so that's really for research, and that can go as long as 3 years that this code is going to be researched, validated. Does it meet the requirements? Is it already covered under another code's definition? And then if it meets that, it may go to a C code where more data is going to be gathered. And then CMS, the AMA will get together and say, okay, it meets the requirements to be a code. There's not another code that describes it. It's a new and innovative technology, and it adds value to the patient, and the data shows that that's validated and proven. And at that point, they would assign that numerical code in the code set, like the 77,000, the 55,000 code set. And it's at that point that the code actually becomes reimbursable. Before then, as a C code and a T code, those are data collection codes. You're not going to be paid for them. So you can see that the process could take 3 to 5 years from the time you apply for a code to the time that you get a billable code. So it's a labor intensive and long process for a reason. Oftentimes people think they have this new and innovative technology, but really it kind of meets the definition of other codes that are out there and could use that code. So that's one of the things that's why the process is a little longer.
So you talked about how codes can meet the same requirements of another code, but if a code has been established, so for us, for radiation therapy, if it's a treatment code, is that the same no matter where you are? Is it the same in Florida as it is in Washington State? Is it the same in Texas? Is that code across the board since it's owned by the federal government or managed by the federal government, and reimbursement rates are just different, but the code's still the same? How does that work geographically?
So, I mean, that's a great question. I think that comes up often, quite a bit as people are like, okay, is that the same code? So yes, nationally, all the codes are the same across the United States. Just like, that we have the same ICD-10 codes. So the billable codes are the exact same across the United States. Now, where it does vary is exactly what you said, is based on your geographic location. When CMS assigns those reimbursements, they are going to vary based on geographic location. Whether you're in like Alabama versus California, obviously the rate's not going to be the same. And there's several factors that influence that. I mean, we can talk about that, how the reimbursement works for these codes whenever, if we want to, here in just a little bit.
So, yeah, we will talk about that here in a little bit, because we're going to talk about how CMS affects patient care, professionalism, affects the way we work, but we'll get to that here in a second. The next question I think I want to ask is, we just talked about codes being standard across the board, but you also said they push out new codes every year, or every, they update them constantly. And at the very beginning, we talked about how it's everybody's responsibility to be up to date on that. So a little bit about how often they change them and why. Why do they change codes? Do they add new ones, or do they adjust the ones they've got? And what is our responsibility as professionals? How on earth are we supposed to keep up with all of that stuff when we're trying to do our jobs on, as frontline staff?
Absolutely. As you know, the way healthcare operates now is not the way it operated 10 years ago. Used to, I think about in X-ray, we did so many more fluoro procedures, upper GIs. We did the barium enemas. A lot of that's been replaced by endoscopy, colonoscopies. So we saw, some of those codes go away, no different than radiation therapy. So every year what the AMA looks at along with CMS is the utilization. What's the utilization of the code? And it's a simple standard deviation. If we see that code really falls on the head or the tail and it's not really being used, they would assume retire that code, delete that code. And as far as revising a code, they may revise the definition to include components of another code. As far as a creation of a new code, again, new technology, one of those codes that's gone for its 5-year period, and they may have decided to award it a code, they may graduate that code from a T code, C code, now to a actual, 5-digit code. And so it's at that point that you would see a new code. You bring up a good point. When these codes are updated every year, how in the world do you keep up with them? This is an interesting process. This is one of those that you need to be responsible for it, but you need to be responsible for knowing it, but it's really how to get that information. So usually these come out in July. The proposed rule will come out in July. So every year CMS will come out with a proposal and say, all right, for this year, for all healthcare, whether it's X-ray, you name it, any modality, these are what are our changes, what we're going to propose. And that goes through a 60-day comment period. And at the end of the 60 days, CMS goes back, they review all the comments, see if, what's legitimate from the people that have said, yes, we should do this, or no, we shouldn't. And then at the end of November, 1st of December, CMS publishes what we call the final rule. The final rule then goes live in January, and those will be the new codes that are adopted, the new reimbursement rates that are adopted. So how would you know that? It would happen in your software that you capture. So we talked about in the beginning that you perform a procedure, that you perform a task that's associated with a code, and then you go to that computer and you do your paperwork and you capture that code. Well, if that code's been deleted, it is on somebody's end when they update that they've populated that data set from your drop-down menu of which codes have been added, which codes have been deleted. And so it's always good to ask. I tell the clinicians, the people on the front line, you're not overstepping your boundaries, but it is good to know, like, who's updating these codes every November, every December. Because I can tell you, things get skipped, things get missed, and it's, you're talking about 99,000 plus codes. Okay, so lots of things can be missed, and there's some code retirements for this coming year that we know are going to change. So it's our responsibility, but you're not going to be the ones adding the codes, deleting the codes. It's going to be the responsibility of the institution's IT department that are uploading it to those charge masters in your codes where you capture them.
So come January 1, when everything changes and, your frontline staff, is there anything that you should know? Is there anything that administration should make available to you? Or do you just hope that the information's there and that you can code it correctly? And what are the consequences? So say, like you said, a code got deleted or a code got changed or something. Well, that's the same code I've been billing for 10 years. So I just continue with that code. What happens when that finally gets caught, mid-spring or something?
So it's interesting you say that. I think if you have staff meetings, everybody should have staff meetings. If this is not, billing coding compliance is not a part of your staff meeting, it's always a good idea. If you're not going to have it throughout the year, at least have it at the end of the year when these changes occur. Because here's what happens. Things don't get updated. You're going to continue, just as you indicated, to capture the exact same codes. So CMS very well may have done an update that said, listen, starting January 1st, you can no longer bill this code. Okay. You may continue to bill it. The hospital may. Obviously, the frontline staff is going to continue to code it, and then the billers are going to send it out the door and bill it. Now, CMS very well may pay it. Medicare may pay the hospital. Oftentimes, CMS will not even catch up to its own rules for auditing's sake for 6 months, 1 year, a year and a half. Now, they can go back 6 years. CMS has a look back period of 6 years that they can go back and collect their money. So that's what we say is money that you billed out the door and were paid for is not necessarily money you collected, because you have to ensure that it was legitimate, that it was supposed to be billed, that the quantity was correct, that it didn't conflict with another code. And that's what the billing department's for, and that's what they use some software for. But it does happen, whether it's to Medicare. You got to remember there's also commercial rate companies. So I don't want to leave them out of the conversation. So it's, your Humanas, your Blue Cross Blue Shield, your Aetna, your United Healthcare. They have their own policies. They don't adhere to what CMS says in Medicare. They oftentimes have their own policies. So you can see where this gets very convoluted, that the billing department's keeping up with a million different rules and making sure things are right. But it won't, as soon as the change happens, it won't necessarily kick it out. It may take, again, 9 months, a year and a half. And believe me, they always come back around and collect their money. So if it's been overpaid, they will get their money.
So speaking like on an institutional level, away from the frontline staff, but on an institutional level, you mentioned that CMS, would get their money. They're going to come back in and audit and see where those, right codes were, wrong codes, may have been charged, where they may have paid too much money in. What can an institution do? What are their resources when it comes to kind of self-auditing, I guess, kind of looking at their own codes to make sure that, they don't get any surprises 6 or 9 or 18 months from now?
So, we'll start at, we'll talk about the hospital, but we'll drill down to start with at the departmental level. So, best practice, and this is what I recommend everybody doing is, if we're looking at, we'll start with radiology and radiation oncology. I think all codes really need to be reconciled daily. What I mean by that is, in that department, somebody should be looking at every patient at the end of the day and making sure, okay, what codes were billed on all these patients, were the codes correct? And the reason I say that is because at the end of the day, at midnight, is when those codes are going to cross into the hospital billing system. So again, knowing that it's right before it leaves is the most important thing. So that's something that I say is have somebody reconcile those charges. Also at the departmental level, I can't stress enough, and hospitals are investing more in this, but education. It may not be education from your institution. It may be education reaching out to somebody like myself or another company, a third-party company, to do a simple 1-hour webinar with your department on what the changes are, what the codes are, what you need to do, what you need to be on the lookout for, what needs to be in your documentation. So that's really at the departmental level. Now, once we cross over and the codes that you coded have been moved over and now they're ready for billing in the hospital, they have tools, solutions, and software to help in that. They use a tool called a scrubber. A scrubber actually is, a lot of people don't understand what a scrubber is looking for is your charges that came out of your department will go through the scrubber. The scrubber looks at two things, something we call MUE, medically unlikely edits, and CCI edits, correct coding initiative edits. On the MUE side, the medically unlikely edit, every CPT code is assigned an MUE, and that's a quantity. And what that is on any one date of service, CMS would expect to see no more than that quantity assigned. So in radiation therapy, most your MUEs are 1. There are codes like the 77300, which are your basic dosimetry calcs that have an MUE of 10. So say you capture 12 of them. And it leaves your department. So in reconciliation, when you're reviewing in your department, you don't catch it. If the hospital scrubber is updated and working correctly, it would catch that and say, okay, throw a red flag. We need to look at this. Somebody needs to look at this. Here's the problem. The MUE edits, the CMS updates those quarterly, so 4 times a year. Again, out of sight, out of mind, you're putting some level of trust into a software that you don't have control over, that it's being updated correctly. The CCI edits that the scrubber reviews are the exact same way. Instead of a quantity, what it's looking for is if I had code X and code Y was billed on the same day, so X and Y, can they be billed together? CMS also publishes a list of all CPT codes quarterly that can either be billed together or not. And so that's important, because what it's going to do is the scrubber would look at and say, okay, code X and code Y were billed together. Is that acceptable? Yes or no? If the answer is yes, it's almost an if-then statement. If it's acceptable, then was there a modifier? CMS will look to see a modifier appended to that code, and there's a long list of modifiers, BID, something done on the same date of service, 76 is, it may be a different practitioner. So that's what the scrubber is going to do. Now you can see the problem there is, again, is the scrubber up to date? Is it working properly? And those scrubbers are hospital wide, so they're covering every service line. So when we look at radiology, radiation oncology, you can see where it gets a little bit different. There's some specifics that have to be accounted for. So they're using the scrubber and much less of a manual process, because that billing department, oftentimes in a healthcare system, is a CBO. So a CBO is a central billing office. And so they may be doing the billing for the entire hospital, for the entire system. So they're not going to spend near as much time, reconciling your department. They're going to run that through, and if everything checks out, that bill's going out the door. So that being said, the hospital has turned its focus to checking it on the front end and ensuring for accuracy. Reason being, if it's wrong on the back end, you're going to get denied from the insurance company, from CMS, and it costs money to fight a denial and time, which means you're interrupting the cash flow of the institution. And it's always better to catch it on the front end. And the easiest place to start, hands down, is education. And it's asking the question. If you're on the front lines, asking the questions about billing, coding, and compliance.
So speaking real quick, because I'm kind of an education nerd. So speaking of education, how often do you, present to departments or facilities? It seems like that would be a very simple way, since you said a lot of institutions are going to that front end checking. It seems like a 1-hour webinar, like you said, a 1 hour, doing something like this, or some kind of short presentation just to catch everybody up to speed. How common is that in facilities? How often are institutions doing that for their frontline employees?
It's not as common as it needs to be, and I think the reason it's not is really the approach and the communication. I think on the front lines, knowing the information and what the impact is, as you go up the chain of command, it needs to be the reverse. It really needs to be the front line and at the departmental level saying, hey, we need this education, and being able to say, if we have this education, this is the financial value that's at stake. And then once the institution sees that, it makes sense to them. And I think so that's one of the things that we really encourage is the departmental staff to be asking those questions. I mean, a simple $300 webinar, we've seen this over and over, equates to not having to pay back $30,000, $300,000 over a 5-year period, $3 million. And now all of a sudden the $300 webinar doesn't look so bad. The worst thing you can do is wait until the panic, until something's really gone wrong. Or, we do a webinar every 5 years. Well, the rules change every year at least. So every 5 years is not going to get it. The other issue is staff turnover. So we know new staff's coming in, staff's leaving. Well, if you put all your eggs in your basket of the person that retired and they knew all this information and didn't share it with anybody, you can see where the problem is. So, and we do, I mean, radiology, radiation oncology, nursing, they have higher rates of turnover. People moving on to other jobs and things like that. And I think that's key, that education really has to stay on the forefront, because no one person knows everything. And I think it's key to stay in touch with the people that know, and be able to communicate with your administrators and upper management of what the impact is, because ultimately, there's a lot of money at risk for them when it could have easily been a simple fix on the front end.
So let's shift gears just a little bit, because everything we've spoken to up to this point has been, what if a mistake's made? What if something's overlooked? Something that really doesn't have a lot of fault associated with it, maybe. So let's talk a little bit about whistleblowers, because they actually catch billing coding, a fraudulent activity. They catch it and report it on purpose. So something that was done with intent. So let's talk a little bit about how a whistleblower, how they track that information, exactly what's going on with fraud, how they track that information, and then how that works once it's reported to the government.
So yeah, years ago, CMS really did all the legwork themselves. And, in the past 5 years, as information's become more readily accessible and more digitized, they're able to go through that data digitally. But what they found was there's probably no better person to catch it than the people on the front end. So the whistleblower, 5 or 6 years ago, 7 years ago, really came out. And what CMS basically said is, if you have a legitimate case where you think fraud's going on, you report it, and you can report it anonymously. You can remain anonymous. You, the whistleblower, would retain some of the monetary findings. So it could be 5%. So you can see where some people took this as a lucrative practice. Now it was a win-win for CMS, because now they're spending less time and money on their staff going after it, and they have people involved on the front lines. And there are cases where whistleblowers that blew the whistle on fraudulent billing practices have made $7, $8, $9, $10, $15 million. And we like to say that everybody's honest and nobody does this stuff on purpose. Unfortunately, that's not the case. Numerous cases, and you can go to the OIG website, Office of the Inspector General, and look at cases. They publish those weekly. Fraudulent cases where, doctors and staff billed procedures for patients that didn't even show up. They overbilled purposefully. And that's one thing, that CMS and the parties involved that investigate will take a look at, is, was this done intentionally? Did you knowingly do it? They also look at the whistleblowers too. Was this a setup by the whistleblower? Is the whistleblower the person that actually did it only to turn around and blow the whistle? We've seen some of those cases. So the whistleblower is very much alive and well. What we say in compliance is you probably should be less worried about the external authoritative source, such as the OIG or Department of Justice, catching you doing something fraudulently, and much, much more worried because it's going to come from internal. You think about it, not everybody is super happy. There are disgruntled employees. If that employee knows that something is occurring that shouldn't be, and there's monetary incentive for them to say something, you can see where that very well may occur. And so we've seen a lot of our hospitals, departments, freestanding clinics really tighten up on their billing compliance side, ethics, compliance, and things like that require compliance plans for every department. Are you covering this in your staff meetings? They're really looking to see if this information is being covered.
So we'll get to the last big topic. And so this is something that you and I have discussed a lot in just the last few weeks. How CMS, how this coding system, how it really can affect not only our profession, but how it can affect patient care and patient safety. So, of course, we're going to speak about the radiation oncology advanced payment model, where CMS is looking at how they pay for things, how they reimburse things, how they recognize things. Also, last night, I was in on a comment where it appears that PET CT is facing kind of some of the same things. They're looking at their PET cardiology, where CMS is not wanting to reimburse it, the same way. So let's talk a little bit about how this really affects not only our patients, but our professional, our professional well-being as well.
Yeah, let's look at it from two aspects. And this really started, it's nothing new. So we used to be what we call fee for service, where everybody was billing codes. It was all based on volume. And then we've seen this paradigm shift over the past 5 years of value-based care, evidence-based care. And really when CMS started looking at this, there's a lot of validity to it. They started with the hip and they started with the hip and the knee model for orthopedics, where they really looked at what is the cost of these procedures and what are the outcomes. And what they found was the cost in certain areas was extremely high, but the outcomes were much worse. So you can see what they were really looking at was how do we streamline this and get it. So then they started looking at bundled payments to say, okay, for this procedure, we're only going to pay X amount of dollars, and you're going to have to achieve a certain level of quality. And so that was proven over a 5-year period, and it proved to be very effective, and it straightened out the outliers. And CMS does this for several reasons. One, they do it to lower the cost, to keep insurance companies from paying more than they should, which makes the rates go up for our patients. And then they also do that for value and quality. So that's what they're looking at. We're seeing the tables turn on this right now for diagnostic imaging as we approach January 1st of 2020 with the appropriate use criteria. The appropriate use criteria is no different than that. So every procedure that you do in diagnostic imaging, when ordered, will be entered into a system, a CDM. And when that's entered, it's a clinical decision-making tool. When it's entered, it's not going to tell you, yes, you can do it or no, you can't. It's going to tell you, again, is it the appropriate use criteria? Is it appropriate? Rarely appropriate? Not appropriate at all. Now, you could still proceed and do it. You very well may not be paid for it. And I think a lot of people, the pushback is, well, how can they say what's appropriate and what's not? It's very simple. It's data-based. So we have 10 years, 20, 30 years worth of data that for this diagnosis, these were the procedures that were done. And again, this is why everything's coded. And then, y'all know what the bell curve is. So what falls under the bell curve is the statistical norm. And this is what we're going to cover. This is how much we're going to pay. Very similar in July for radiation oncology, we had what we called the APM, the alternative payment model was introduced. Very similar to the appropriate use criteria, where they said, okay, we're going to take 17 disease sites. So prostate, breast cancer, bladder cancer, colon cancer, anal cancer, brain metastasis. So they take these and they say, okay, for a course of radiation treatment, really this is how much we're going to pay. And again, I think the knee-jerk reaction was, well, how can they say that? Again, it's data-driven. We know that for this ICD-10, so every disease, every diagnosis has a code. So we can say for that code, when these patients got radiation, this is the codes that were used, most commonly. And then, of course, there were the outliers at the head and the tail of the standard deviation curve. And so, really what this does is, it's because of fraud and abuse. Again, I like to say that it doesn't happen, but a lot of people have taken advantage of the system and done a lot of things they shouldn't have done and been paid for a lot of procedures. And CMS realizes that, and it's a mechanism for them to control costs, but also ensure that things are being done that are evidence-based, not just because somebody wants to do it because it reimburses more. Or pays more. So in my mind, I think we're going to continue to see this amongst all service lines. It's not just radiology. You're going to see this for a lot of your surgeries, comprehensive approaches to medicine where they're going to have a flat rate medicine and approach to that. I think of immunotherapy and chemotherapy for cancer patients. We all know that there's new drugs that come out. And I think what CMS is going to say is no different than orthopedic equipment that comes out for orthopedic surgery is, what's the value of that? Is it is it 1% better? Is it 2% better? And if the cost is $400,000 more and only 1% better, are we going to cover that? And if we are going to cover that as an insurance company, as CMS, how much are we going to cover? And so again, I think it's going to take some getting used to. It's going to change the way we approach medicine for our patients. It's going to change the way we approach things in our workflows, but ultimately, it's about quality for the patients. Right now, we're in an era of what I call patient consumerism. So no different than you checking the newspapers or checking online to see what the price of something is. Patients are doing the same thing. Healthcare is the only service where, you know, you go to Walmart, you go to the grocery store, wherever it is, you look at a price tag, you know how much it costs. Not in healthcare. The only place where you don't know that. They can tell you, but it may not be accurate. You may owe some money. Your deductible may not be met, your copay. So this is really what CMS is trying to get away from. They want patients to know to be able to make an informed decision. Legislation's been passed about surprise bills for where patients, you know, legislation is there to prevent people from sending surprise bills to patients. So you didn't tell the patient, oh yeah, by the way, it's an extra $5,000 and you drop a bill on them. Legislation's in place to prevent that. There's also transparency laws. So right now, hospitals are required to publish their charge masters online at their website so patients can see how much procedures cost. So you're going to see more and more of that. And again, it's a paradigm shift for medicine. I think a lot of people are going to fight it. I think it's a losing battle. I think CMS is committed. They've proven in their data how much fraud and abuse there was. And, you know, I guess a few bad apples can make it bad for all. And these are the rules and the guidelines that we're all going to have to play by. The key is, as all this changes, is, again, education. I can't stress that enough, because with the education is when you're going to be able to make the adjustments and the changes to be on the front end of this. You don't want to be on the back end of it.
So I believe, you know, kind of, we've given everybody an incredible overview of billing and coding and how the codes work, where they come from. But I still think, you know, you continue to go back to education. And I think as a professional, it's kind of your ethical responsibility to keep yourself informed. I want to comment about like I said, I was talking to the PET cardiology folks about the CMS changes, and this is all part of keeping yourself informed. So those people knew what was going on, they knew what changes may be around the corner, but there's some recourse there, correct? So there's a comment period. So if you'll explain that comment period just a little bit, and then we'll wind this up with how important it is for everybody to buy into the good education and information that's necessary. So a little bit about the comment period.
Yeah, absolutely. So no change really just happens, okay, in healthcare and with these codes. It's always proposed, and there's always a comment period. No surprise here. A lot of people just simply don't comment. So then the change is enforced, and then everybody's really mad. We don't know how this happened. We don't know why this happened. Well, you had 60 days to comment and you chose not to, or you wanted your professional society to do it. And let me tell you, the professional societies can only do so much. Those that are involved in the profession really have to arm, because you're on the front lines, arm the profession, arm the professional societies with the data that they can then go to CMS and to the authoritative guideline makers, the AMA, CMS, with the data. You can no longer go to these people with emotion, and we just don't like that idea. Well, show us the data and validate your point. And if you cannot prove your point with data, you're not going to have a case. And unfortunately, there's not enough involvement. And so oftentimes the changes just get made, and then we just, you know, we have to live with those changes, and that's not necessarily the case. I think some of it is we're extremely busy, and it's like, you know, am I going to give up the time to make that comment or talk to somebody or try to get a group together? And I think that's our professional responsibility. I think, you know, part of that falls on, don't wait for somebody to invest in you. At a minimum, invest in yourself. If you know where the information is, you can go get that. There's too much information out there that's really affordable. And there's a lot of information out there that's free, and people still don't take advantage of that. And so I think that's important. I think that's important to take a look at.
So I think probably the perfect way to wrap this up is to say something like, for us as professionals to ensure that patient quality and that patient safety is for us as professionals to stay educated, informed, and invested. Invested is a very important, component of all that. And I think that's the best way for us to continue to deliver the patient care that those patients deserve, is for us to take the time to educate ourselves, invest in ourselves, so that we can be a better version of the person that's the professional that's delivering the service for our patients.
No, absolutely. I mean, I think it's in some levels, it's a job protection mechanism for us to ensure that we keep our jobs. Quite frankly, these changes are going to happen. There's people up the food chain in the systems that are going to get involved, and a lot of people will have choices. We can either get involved or not get involved. But when the changes happen, there are other changes that are going to have to be made to offset some of those changes or help meet the need. And so that whole other category that's in your job description, other encompasses a lot of things. And I think self-investment and being able to ask the questions. I think far too often it's as simple as asking a question, but we get so laser focused on just our day-to-day task, and it's easy to do, but you really have to step back and say, what's the bigger picture here? And some of that is that self-responsibility.
Well, Jordan, thanks a whole bunch. I mean, I learned a lot. You and I do talk about this all, but before we had these conversations, this was not an area of expertise for me. So, and I think that's probably generally across the board, that, like you said, people get so busy in their day-to-day jobs that this is not something they focus on, but maybe they should put a little bit of investment into it. And I thank you for explaining everything to us.
No, thanks very much. And if anybody has any questions, just more than happy to help, let me know. But thank y'all. Thank everybody for what they do, and thanks for taking care of the patients. Again, that's first and foremost, and then take care of yourself. So thank y'all very much.
Real quick, if somebody did want to reach out to you, just to ask some questions, like you said, there's a lot of free information out there. I know they can find you on social media. That's where I find you. Or they can, email you. Do you want to leave that information, or do you want to maybe just find you on social media? Do you think that's the best way?
It's pretty straightforward. I mean, it's funny. You make the ask to people and you say, hey, I'm available if you need, and then nobody contacts you. So yeah, I'm on LinkedIn. It's under Jordan Johnson. My email is straightforward. It's Jordan, Jordan at Legion, LEGIONHP.com. Reach out to me. I mean, that's what I'm here for, here to help. Even if it's you don't know the question to ask, but you think I could talk to somebody at your institution that may be able to get you the help you need. That's what it's all about. It's somebody that's willing to help. So those are the best ways to get in touch with me.
Thanks, Jordan.
All right. Thank y'all so much.